So today we are lucky to have the pleasure of hosting Dr. Hooman for a talk on the Pulmonary Embolism Response Team. Dr. Kaur received his undergraduate training from Dartmouth College, where he studied physical chemistry and mathematics. He obtained his medical degree at Columbia University and stayed there at Columbia Presbyterian for his training in internal medicine and pulmonary and critical care medicine. In 2013, he joined our faculty here at the Icahn School of Medicine at Mount Sinai and has dual appointments in both the Division of Pulmonary and Critical Care and the Division of Cardiology as an assistant professor in medicine. He is also the director of the Pulmonary Vascular Disease of the Mount Sinai-National Jewish Health Respiratory Institute and founded the Multidisciplinary Pulmonary Embolism Response Team at Mount Sinai, which we are about to hear about. Dr. Kaur is a dedicated clinician educator and has received a number of teaching awards from colleagues, students, and house staff, including the prestigious Solomon Person Award, which is awarded to a faculty member who has made the most significant contribution to house staff education. Please join me in welcoming Dr. Kaur.
Thank you, Nelly, for the introduction. And thank you, everybody, for coming this morning. Today we're going to talk about pulmonary embolism and specifically the Big Clot. So my disclosures, I have no financial disclosures, but I should probably disclose that this talk may incorporate unnecessary and superfluous pictures of my daughter. That's her. She's going to help me with this talk. So I'm going to start out with a case. 73-year-old woman, history of hypertension, hyperlipidemia, comes in with sudden onset of shortness of breath and syncope. This is actually a case I saw when I first started here at Sinai as an attendant. She was normotensive, tachycardic, heart rate in the 114. O2 sat was 95% on 2 liters nasal cannula. This is her CAT scan. This is the main PA. This is the right and left. You can see a little bit of clot, but as you go downwards, you see a lot of clot in the right PA, left PA. And you can see when you go down to the heart that this is the right ventricle here. It's much bigger than the left ventricle. The septum is bowed, and it looks like a D, not an O. Echo was done. She has normal EF and severe RV dilatation and dysfunction. She has the flattening of the septum, as we saw in the CAT scan, and moderate tricuspid regurgitation, elevated RVSP. Because of the syncope, a head CT was done, which was negative. She was started on a heparin drip. So the question is, what do you do next? Do you continue anticoagulation and cross your fingers? Do you transfer to the MICU for systemic thrombolysis? Do you call CT surgery for surgical embolectomy? Do you call IR for catheter-directed thrombolysis? Do you call palliative care and transfer to a KP6? Or do you use your trusty magic 8-ball and decide between the above choices? So the objectives I have for this talk are mainly to discuss what actually happens hemodynamically in these PEs, how we risk stratify pulmonary embolism. I'll talk a little bit about the data behind thrombolysis for pulmonary embolism. And finally, I'll talk about our risk stratification algorithm and our multidisciplinary PE team. So my fellows are probably rolling their eyes because every talk I give them, I always start with this equation here. And it's Ohm's law, which is V equals IR, a voltage difference across a resistor. And we can use this equation to understand the pulmonary circulation. You can also use this for the systemic circulation. You can use this for a ventilator. You can use this for pretty much all of life. And so instead of a voltage difference, we use a pressure difference. Instead of the flow of electrons, it's a flow of blood, which is the cardiac output. And the resistor is the pulmonary vascular resistance. And the pressure difference we're looking at is the pulmonary pressure, the mean PA pressure here, and the downstream pressure is the left atrial pressure. And if we rearrange this equation, we now have an equation for the pulmonary pressure. So with this equation, if we imagine that our pulmonary circulation is made out of lead pipes, then you would have a right and left main PA. And if you were to block off one of them, ignoring the left atrial pressure for now, this would double the resistance, and your pulmonary pressure should double. However, this is not the case. In fact, this is a study of 30 patients with pulmonary embolism who did not have prior cardiovascular disease. And as you can see, their degree of pulmonary vascular obstruction and the resistance is not a linear relationship. And in fact, as you increase the obstruction, the resistance doesn't really increase all that much until you reach a certain point. And it's actually a hyperbolic curve. And this is the reason why we can do certain procedures. For example, we can do pneumonectomies, where we take out a whole lung. We can do single lung transplants, because if you imagine, if we take out a whole lung, then the vascular resistance would shoot up, the pulmonary pressures would shoot up, and we wouldn't be able to do this. And so in the 60s, there were a lot of studies done to essentially evaluate this in order to see if they can do pneumonectomies. And so in this study, patients that were being evaluated for pneumonectomy, they had their mean PA pressures measured. In this case, it was 19. And then they would put a balloon and completely occlude one of the main pulmonary arteries, either the right or the left. And as I said before, if made out of lead pipes, it should double. And in fact, it did not. It barely rose. It went up to 24. So you can knock off half of your pulmonary circulation, and you will barely have a rise in your PA pressure. So that's because your vasculature is not made out of lead pipes. And in fact, they can distend. And not only that, your capillaries at rest are kind of collapsed. And if you increase the flow and pressure through them, they will engorge and dilate. And when they dilate, the resistance decreases. So with increased pressure, you have increased dilation, and the resistance will drop. Interestingly, though, this is a study of patients who had acute pulmonary embolism with no cardiopulmonary disease at baseline. And this is a relationship between their mean pulmonary artery pressure and the amount of obstruction they had on angiogram. And so just to orient you about these numbers, a normal mean PA pressure is 14. The upper limit of normal, so that's 2 standard deviations above the mean, is 20. And we define pulmonary hypertension as greater than 25. So this zone between 20 and 25 is this hazy zone. So if you look at PA pressures greater than 20, you see that you only need 20% obstruction. So I was saying before that 50% obstruction barely increases your PA pressure, whereas in an acute pulmonary embolism, this increases your pressure with only 20% obstruction. And so my daughter was thinking about this for a very long time and contemplating this issue while drinking a glass of rosé. She's actually holding it. And specifically, how can 50% obstruction with a balloon cause minimal increases in PA pressure, whereas as little as 20% obstruction with a pulmonary embolism can result in significant increases in PA pressure? And the answer is we're dealing with platelets, okay? And so the reason we have platelets aren't to give us pulmonary embolism. The reason we have platelets are essentially to stop bleeding and hemostasis. And so when we look at hemostasis, part of the hemostatic pathway is to induce vessel spasm and vasoconstriction to prevent further bleeding. And so platelets play a significant role in this to constrict those vessels, to decrease the amount of bleeding, to allow for a plug to occur. And so a sheep experiment was done, and you'll see why I use the word creeping in just a second. 14 pairs of sheep, and they took the carotid artery of one sheep and connected to the internal jugular vein of the other, and then the carotid artery of the other sheep and connected it back to the sheep A. And so this was sharing a cardiac output about 10 to 15%. And they gave one of the sheep a pulmonary embolism. And when they did this, you could see that the PA pressure of sheep B would go up, as you would expect with a pulmonary embolism. However, the sheep A also had an increase in pulmonary pressure. So something was being shared within this cardiac output that was resulting in an increase in cardiac output, an increase in pulmonary vascular resistance. And so the platelets have vasoconstrictive activating factors, specifically serotonin and thromboxane. And so these are very vasoconstrictive substances that increase the pulmonary vascular resistance. Interestingly, the way that unfractionated heparin works is that with antithrombin 3, it inhibits factor 10A and also thrombin. And many times we see patients who come in with acute pulmonary embolism, they're short of breath, and you start them on heparin, and heparin really is just stopping coagulation. It really shouldn't cause fibrinolysis. Yet, magically, within a few, pretty quickly, they feel better. And the thought is that you are stopping this activation of platelets by stopping thrombin generation. So the other aspect of the hemodynamics is that when you look at this, patients who don't have prior cardiopulmonary disease, who have acute pulmonary embolism, will never achieve a mean PA pressure greater than 40. And to understand that, you have to go through what happens with afterload. Afterload is defined as the amount of work the heart has to do to eject a certain amount of blood, essentially the wall stress. The left ventricle can tolerate large amounts of afterload. In this study here, the aorta is clamped, and you can see that the pressure increases, and the stroke volume does not decrease all that much. However, if you were to do the same thing with the right ventricle fails immediately. So the right ventricle cannot tolerate increases in afterload. And again, this is the equation that I showed you before. And cardiac output is equal to stroke volume times heart rate. If we increase the vascular resistance by adding more and more clot, the vascular resistance will go up. However, as you increase the amount of vascular resistance, the afterload of the right ventricle will go up and the stroke volume will fall. And therefore, you will reach some kind of plateau here. So the pressure will kind of plateau. This is not true if you have pre-existing cardiopulmonary disease, because these are patients who have increased RV afterload for a prolonged period of time, which results in hypertrophy of the right ventricle. This is a study of patients with various diseases and their mean PA pressures after acute pulmonary embolism. So those who are normal have a mean PA pressure always below 40. However, those who have, in this case it was called coronary heart disease, have increases in PA pressure, aortic valve disease, chronic lung disease, and mitral valve disease the highest. So when you have increases in PA pressure that are above a mean PA pressure of 40, this reflects prior cardiopulmonary disease. And so what happens when a patient with acute pulmonary embolism decompensates? So initially, it's an increase in right ventricular afterload. And as I showed you, with the increase in right ventricular afterload, this results in a decrease in right ventricular cardiac output. The right ventricle is what supplies blood to the left ventricle. So the left side preload goes down, and ultimately your left ventricular output goes down. Additionally, when you increase the RV afterload, the RV wall stress goes up. If you increase the wall stress, essentially you're increasing the demand without the supply, and that results in ischemia. If you have an ischemic right heart, it can't pump out as well, and your RV output goes down. When you increase the RV afterload, it dilates. And from Laplace's law, the bigger the chamber, the more wall stress there is. As you increase the size of the RV, it increases at the expense of the left ventricle. And so this is the septal shift that I showed you on that CAT scan. And if you have this increase in leftward septal shift, the filling of your left ventricle goes down. Additionally, your tricuspid valve coaps like this, and as your right ventricle dilates, it pulls them apart, and you end up getting more tricuspid regurgitation, and therefore you have less effective RV output. And part of your left ventricular output is your coronary circulation, and if you get a decrease in your RCA blood flow, that results in RV ischemia. And ultimately, this will lead into cardiogenic shock. Now, there are certain things that we can do to hasten this process. One of them is to give lots of fluid, and the other is to intubate the patient. And so, giving vasodilators like propofol, for example, cause peripheral vasodilatation, and now all the blood flow that should be going to the RCA is going to the patient's kneecaps. So what are some things that we can do beyond anticoagulation? Because standard therapy at this point for PE is to prevent the next one and allow your body to get rid of the clot that's already there. But in cases where we need that clot to be removed immediately, what can we do? Well, we can surgically remove it, or with interventional radiology, we can go in and try to actually remove it. Or we can give medications to break it up. This is a real thing I found on Google. The vascular roto-rooter clot buster specialist. I'm going to see if we can put this on a formulary. But thrombolysis, and I'll talk about that. But a lot of the thrombolysis trials have been negative, and I'll talk about some of the more recent ones. And the question is why? Is it because the harm and benefit are equal? And how can we address this to actually help patients with significant PE? And perhaps the reason that it's been, there's no difference is that there are two populations. There are some that would benefit, and there are some that would not benefit. And that we need to risk stratify the patients to figure out who are the ones that increase risk to be able to give them the necessary therapy. And so one way to risk stratify patients is using the Pulmonary Embolism Severity Index, the PESI score. And this was a study done back in 2005 where they looked at 15,000 patients in Pennsylvania who had acute pulmonary embolism using ICD-9 codes. And what they found were these predictors that were independent predictors of 30-day mortality. And based on these beta coefficients, they had points assigned, and they created a score. And so if your PESI score is low, you are low risk. If your PESI score was high, you are high risk for 30-day mortality. And again, these predictors are demographic characteristics, comorbid illnesses like heart failure, cancer, and chronic lung disease, and essentially vital signs. And what they found was 30-day mortality in the derivation and internal validation sample, as well as an external validation sample in Switzerland, 200 patients. Those who were low risk, class 1 and 2, had very low mortalities in 30 days. Those who were higher risk, class 4 and 5, had higher mortality. And this also correlated with inpatient mortality as well. So again, very low risk of inpatient mortality if your PESI score was 1 or 2, higher risk if it was PESI 4 or 5. And this led to an actual randomized controlled trial where the idea was to take patients who were very low risk, PESI 1 and 2, and see if you could just treat them as outpatients. Don't even admit them to the hospital. And so these were patients, PESI 1 and 2, randomized to being admitted to the floor, anticoagulated for 5 days and bridged to Coumadin, sent home, versus being sent home immediately on Lovenox and transitioned at home. And the primary endpoint was recurrent VTE at 90 days. And in fact, there was only one patient that had a recurrent VTE in the outpatient group and none in the inpatient group. This one patient had it on day 83, and she had cervical cancer and was on Lovenox. There was one mortality in each group. One died from lung cancer and pneumonia. The other died from an aortic rupture, I think from a car accident. But the point being that these very low-risk patients can be treated at home. They do not need to be in the hospital. However, this is not a very good score for high-risk PE, in the sense that you can imagine if you have a 120-year-old patient with metastatic cancer, bad heart failure, and severe ILD, they can have the smallest PE in the world, but their mortality is still really high. It doesn't mean that we should run to do something for their PE. So how do we risk stratify these high-risk patients? And we look at the MAPIT study. This is not the MOPIT study, the MAPIT study. And they looked at 1,000 patients with acute PE. And what they found was those who had hypotension without shock, so this is a low blood pressure without clinical signs of shock, had a mortality of 15%. Those who had hypotension with shock, so signs of end organ damage, had a mortality of 25%. And those who required CPR had a mortality of 65%, which is actually lower than I would expect. But in any case, this already is a risk stratification algorithm to say that these are high-risk patients and something should be done. This is the ICOPER study, and again, looked at massive versus non-massive PE and 90-day mortality. You could see that massive PE has a significantly higher mortality, about 51% versus 15%, and this mortality is from cardiovascular mortality. They are dying from their PEs. And in that same study, a systolic blood pressure less than 90 was the single strongest independent predictor of mortality, hazard ratio of 2.9. And so because of this, the AHA has come out with the definition of massive PE, and it's defined as having an acute PE with sustained hypotension. So that means your blood pressure, your systolic blood pressure is less than 90 for at least 15 minutes, or if you're requiring inotropic or vasopressor support. And this cannot be caused by something else. So you cannot be septic or have left ventricular dysfunction or an arrhythmia. If you're pulseless, or if you have profound bradycardia with signs of shock. This is the definition of massive PE. It's important to note that massive PE is not defined by the amount of clot. And so in this MAPIT study, there's also a fourth group, and this group is known as those who have RV strain or pulmonary hypertension, and their inpatient mortality was 8.1%. So, and you can see here in the ICOPER study, again, those who were normotensive, systolic blood pressure greater than 90, and RV dysfunction, those who did not have RV hypokinesis had increased survival compared to those who do. And you can see there's a huge difference here. Like the white and from here to here is very, very big. And I kind of say this facetiously because I removed the y-axis. And the point here being that this is 96% versus 91%, and this difference is relatively small. It's there, but it's small. And the importance of this is that any intervention that we make in these patients has to have a smaller risk profile than this difference that we're going after, okay? So the scientific statement from the AHA, they define submassive PE as acute PE without systemic hypotension, so your systolic blood pressure is greater than 90, plus one of the following. You have RV dysfunction and the presence of at least one of the following. So RV dilation, and this can be measured via echocardiography or CAT scan, elevated BNP or end-terminal pro-BNP, or actually having even EKG changes consistent with RV strain. Or you can have signs of myocardial necrosis, so specifically an elevated troponin, either I or T. And so the way I look at massive and submassive PE is via Wiley Coyote. Massive PE is essentially free fall in the sense that the patient is actively hypoperfusing. There is tissue hypoperfusion and end organ damage, and something needs to happen now in the sense that it will not get better by itself. Whereas submassive PE, you're essentially at the cliff. And you have not fallen off the cliff, but you're at risk for falling off the cliff. And the goal is that you should be pulled away from the cliff, and ultimately, if you happen to stay on it and not fall off and go backwards, then things are fine. But the problem with submassive PE is that not all submassive PEs are created equal. So this is a submassive PE, this is a submassive PE, and this is submassive PE. And so the idea is, how do we differentiate between these types of submassive PE? Because we would like to intervene on this one and not necessarily this. He could just turn around and walk backwards. And at the end of the day, we want to prevent the submassive PE from turning into a massive PE. When I figured out how to do that on PowerPoint, I was really excited. Really, really excited. Okay, so can we further risk stratify? Can we take this submassive group and look at even the higher risk patients within them? And perhaps we can do this with troponin. And in this cascade of RV failure, troponin really is looking at the RV ischemia portion. And so this is a meta-analysis of patients with acute pulmonary embolism, looking at short-term mortality and adverse events. And having an elevated troponin, either I or T, was associated with an increased odds ratio of that event happening, 5.24. This was an Italian study of about 900 patients with normotensive acute PE. And they looked at whether they had RV dilatation or not, and whether they had positive troponins. And they looked at their 30-day mortality and adverse events. So if you had no RV dysfunction and a negative troponin, you had very low risk. In fact, nobody died in 30 days. If you had RV dysfunction or a positive troponin, one of them, you had an elevated risk, a hazard ratio of 7.9 for this event happening. And then if you had both of them, your risk was even further higher. So the point being that the RV dysfunction and troponin are additive. It's not one or the other. It's both combined will give you information. And so I was very interested in risk stratifying the high-risk patients. The hospitalists, particularly Trini Trong and Andy Dunn, were very interested in the low-risk patients and decreasing their length of stay. They were staying in the hospital too long, getting all these tests, when they could have just be sent home early. And so we joined forces and created this combined algorithm, which is the kind of risk stratification algorithm. So you essentially know all these pieces based on everything I just told you. So if you're diagnosed with an acute PE, first start anticoagulation, but then you ask if any of these are present. The systolic less than 100 and the O2 sat less than 90 were exclusion criteria in that outpatient Odjeski trial, which is why we left that there. If you have altered mental status, you already get 30 points, or 60 points, so you're almost going to be class 3 anyways. And if you have syncope, you should probably be evaluated. Syncope from a PE, that is. So if you don't have any of these, then you calculate your PESI score. The score is up here. And if you're low risk, class 1 and 2, you now fall into that Odjeski trial and can be sent home on rivaroxaban or Lovenox if your renal function is okay and if you have essentially the social support and the means to obtain the drug. If you go down this pathway, then you have to further risk stratify. So the first question is, do you have a massive PE? And if you do, call the MICU fellow. And if not, then you further risk stratify with an echo, troponin, BNP, and here are some high-risk features. If these are present, then also call the MICU fellow, and I'll discuss that in more detail. So my daughter was asking, can we use thrombolysis to prevent a submassive PE from deteriorating into a massive PE? And so again, we're trying to prevent this from actually happening. And this was a recent trial that was done. I'm not going to go through the older trials, but this was the PEITHO study, a big trial that was done, that was published in the New England Journal last year. And so essentially what they did was they looked at, this is their risk stratification algorithm here. For those who have clinical shock or hypotension, they are high risk. They should get thrombolysis or embolectomy. They are not in this trial. Those who have nothing in terms of no shock, no RV dysfunction, no myocardial injury, they are low risk. It's this intermediate risk that we're looking at, and they skimmed the top. They looked at those who are at the highest risk, i.e. those who had both RV dysfunction and myocardial injury as noted by an elevated troponin. And so what they did was they randomized them to thrombolysis with tenecteplase versus heparin. And their primary outcome was all-cause mortality or hemodynamic collapse within 7 days of randomization. So this is 7 days, a trial of 7 days. And hemodynamic collapse was defined as requiring CPR, your blood pressure dropping to below 90 or greater than 40 with end organ hypoperfusion, or if you required pressors. And so the results were positive in the sense that those who received, so this is a large study, 1,000 patients, those who received tenecteplase had a lower rate of reaching this primary endpoint of all-cause mortality and hemodynamic collapse at 7 days. So 2.6% versus 5.6% in the placebo group. And you can see the odds ratio was 0.44. However, when you look into the details of this trial and exactly the components of this primary endpoint, the all-cause mortality was no different. So specifically, the mortality in the placebo group was 1.8%. So that's already a very low mortality in a trial of 7 days versus 1.2%. And the reason the primary endpoint was achieved was essentially because of this hemodynamic collapse. So 5% versus 1.6%. There was no difference in PE recurrence, no difference in intubation, and the placebo group received open label thrombolysis later. So the second they met that primary endpoint, the trial was over for that patient, then the PI would say, okay, thrombolyse them, they have a massive PE. Okay, so the idea was that they didn't get lysed early, they got lysed later. And so this came at a cost. You can see that there was increased bleeding in the tenecteplase group. So non-intracranial major bleeding was 6.3% versus 1.5%. And the dreaded hemorrhagic stroke rate was higher. So you could see 2% hemorrhagic stroke rate in the tenecteplase group versus essentially nil, just one patient, 0.2% in the placebo group. So in summary, thrombolysis for submassive PE as defined in this study reduces the risk of deterioration to massive PE. It increases the risk of hemorrhagic stroke, 2% versus 0.2%, but there's no survival benefit when you do this. And so in my mind, the risks of systemic thrombolysis for submassive PE outweigh the risks. Outweigh the benefits. But one huge take-home point from this study is the following, that this is a randomized controlled trial. There are research coordinators hounding these patients. They're watching them exceptionally carefully. And despite that, 5% of patients had hemodynamic compromise, which means at the very least, if you have a patient who falls under this category, they need to be monitored carefully because the second their blood pressure drops, they need an intervention immediately. In this case, it was thrombolysis. So my daughter was really upset. She was really looking forward to thrombolysis. She went to the bottle. Please don't call Child Protective Services on me. I don't let her drink all of it. And so she asked the question, is there a way that we can reduce the risks of thrombolysis? And so I'm going to talk a little bit about what TPA actually is, and this is a very complex diagram. So this is plasminogen, and plasminogen is the inactive form of plasmin. And to get from plasminogen to plasmin, we need the plasminogen activator. And the plasminogen activator works when it's bound to fibrin. So when these are both bound to fibrin, the plasminogen activator works. So this is fibrin specific and therefore will act only on clot. And therefore the plasmin is activated and starts chewing up fibrin. There's alpha-2 antiplasmin, which binds the free plasmin, but the fibrin itself kind of protects the plasmin from actually being inactivated. So a little history of TPA. In 1947, it was found that animal tissues contain this agent that activate plasminogen, and it was called fibrinokinase. In 1952, it was actually extracted from animal tissues. In 1979, the first highly purified form of human TPA was obtained from uterine tissue. And then in 1982, cloning and expression of human TPA was achieved in E. coli, and this is where we get recombinant TPA. In fact, now I think we get it from Chinese hamster ovaries. And ultimately, in 1984, the first randomized controlled trial was done for TPA in acute MI. And this was the trial for acute MI, and this gave rise to the 1.5 million TIMI trials that followed. Essentially, the point of this is that the dose that was used in this trial was 100 milligrams. And it was 100 milligrams, I think, over 2 hours. And all the TIMI trials that followed were kind of variations on this type of dosing. And so 4 years later, a randomized trial was done in pulmonary embolism comparing it to urokinase. And this was 44 patients. They were hemodynamically stable, and they were randomized to urokinase or recombinant TPA. And the primary outcome was repeat pulmonary angiography after 2 hours. And so those in the recombinant TPA group had 82% evidence of lysis versus 48% in the urokinase group. But the point is that urokinase is a 24-hour drug, so this is an unfair comparison. But despite this, the package insert now for alteplase, which is recombinant TPA, says for PE, the recommended dose is 100 milligrams administered by IV infusion over 2 hours. So this is extrapolated from MI data, this study that really is not that great. And now we say that, quote unquote, full dose TPA for pulmonary embolism is 100 milligrams over 2 hours. This is where this came from. So if we actually look at where this drug goes, we should look at the cardiac output and the relative perfusion to the different organs. So the coronary circulation, with respect to MI, takes about 4% of the cardiac output. With respect to stroke, 13% for the head and neck. Yet the pulmonary circulation receives 100% of the cardiac output. So, you know, my daughter was thinking about this even more, and her question was, are the same blood levels of TPA used in thrombus for the coronary and cerebral circulations necessary for thrombus in the pulmonary circulation? Can we use lower doses because so much more of the blood is going to the pulmonary circulation? And in this harm-benefit ratio, perhaps if we reduce the risk of the TPA, that we can actually alter the risk-benefit ratio. So this would be reducing risk reduction of the intervention. And so this brings us to the half-dose thrombolysis of 100 milligrams versus 50 milligrams. So there was a study in chest 5 years ago, essentially looking at 50 milligrams versus 100 milligrams. And so there was 118 patients with massive or submassive PE, and they were randomized to 50 milligrams versus 100 milligrams. And they looked at a whole bunch of endpoints. So they looked at the ratio of the right ventricle and the left ventricle at 24 hours and 14 days. And you could see that there's no difference, that the ratio improved in both of them. The RV got smaller relative to the LV. They looked at the right ventricular wall motion. Both of them improved at 24 hours and 14 days, really no difference. They looked at the systolic pressure of the PA, again, going down with thrombolysis, really no difference at 24 hours or 14 days. They looked at the lung perfusion defects as measured per VQ scan. Both of them improved in the same way at 24 hours and 14 days. And they also looked at large artery obstruction via angiography. Again, both improved 24 hours and 14 days. So really, the effectiveness of 50 versus 100 really no different, but the huge difference was there was a decrease in bleeding complications. So those who had 50 milligrams of TPA, 17% bleeding complications versus 32. This is essentially statistically significant. So my daughter was excited, and she asked, can we reduce the dose of thrombolysis even further? And so this is where catheter-directed thrombolysis comes in. So remember, full dose lysis is 10 milligrams followed by 45 milligrams for 2 hours, which is 100 milligrams total. So what if we put in two catheters, one in, so this is the main PA, this is the right, and this is the left, and these holes here have ports where a drug can come out. So what if we do this quote-unquote low-dose catheter-directed lysis, where we drip 1.5 milligrams per hour total for 16 hours. So you get 24 milligrams over this time period, over a prolonged period of time. And so the reason this makes sense is for the pages that I would get as an intern at 2 a.m. And so you get a page at 2 a.m., you have these critical lab values, sodium 96, chloride of 85, and glucose of 4,500. And as an intern, I'd be freaking out, oh my goodness, so I diligently would run upstairs, look at the patient, patient's kind of looking at me like, what's wrong? So I look at the patient, and clearly there's an IV, and there's D5W infusing here, and there's a Band-Aid here. And so the point being that this is actually a real lab value, that the concentrations of sodium, chloride, and glucose really are true here, and that it's just a concentrated version of this here. So there's lots of water and dextrose here. However, there is not that concentration of water and dextrose in the brain. Otherwise, the patient would be seizing and would not be alive. So this is the same concept with catheter-directed thrombolysis. Can we instead drip TPA at a very small rate, directed here, to increase the concentrations here, such that those concentrations are not achieved in the brain, so you don't get your hemorrhagic risk? And a trial was done. This is a small trial last year, and looking at 59 patients with submassive PE, and they defined this as an RV to LV ratio greater than 1 on echo. So you could see RV greater than the LV. And they were randomized to heparin versus this catheter-directed thrombolysis. And the way they did this was they gave 1 milligram an hour for 5 hours and then 0.5 milligrams for 10 hours per catheter. So again, a similar type of protocol that we use here. And the primary endpoint, not the best primary endpoint, but it was a change in this ratio at 24 hours. And as you could see in the catheter-directed thrombolysis group, this ratio decreased from 1.28 to essentially 1. And there's really no difference in the control group. And this was statistically significant. And there's very little bleeding. Transient hemoptysis in 2 patients, one with access site hematoma and one with a muscular hematoma. Very small study, and the primary outcome is not necessarily that clinically relevant, but at least with this very low dose, we can show hemodynamic signs of improvement with the RV-LV ratio. So you have all these options. What are you going to choose? Right? You have all these different therapies, whether, I didn't really get into surgical embolectomy. I'll talk about some case reports about that. But which one are we going to choose? So we can look to guidelines. Guidelines will help us decide whether we should lyse patients or not. And so as we go to the guidelines, the AHA says fibrinolysis is reasonable for patients with massive acute PE. Fibrinolysis may be considered for patients with submassive acute PE. Okay, we'll look at the ACCP. Maybe they will guide us. Thrombolytic therapy depends on the clinician's assessment of PE severity. So the point being that there really are no hard and strict guidelines to be able to tell us what to do. And because of that, we've developed this pulmonary embolism response team, which is a multidisciplinary team of people who, for some reason, are interested in PE, and who can contribute from their specific specialty. So we have interventional radiology, cardiothoracic surgery, pulmonary, vascular medicine, and myself. And so it was created in July of 2014. And it really is just a resource for timely deliberation and, of these high-risk patients for possible recommendations of advanced therapies. And also it results in rapid mobilization of resources and personnel. So you can get the people that need to do things there very quickly. And since 2014, we've discussed 66 cases. We've been called probably twice that, and I've kind of not discussed all the cases with the team because many of them were lower risk patients. We've done 19 catheter-directed thrombolysis cases, 5 systemic thrombolysis, and 10 went to the OR. And how do we call this team? Essentially, you could either directly call one of those members. Each member will sometimes present cases. Or with this algorithm, you merely just call the MICU fellow. The MICU fellow then will contact the team, and things will move from there. So I just wanted to highlight some of the cases that we've had in the past few months. The first case is, I saw, I think, last month, actually. 30-year-old man, no medical history. He came in with pleuritic chest pain and dyspnea on exertion for a couple days. Excellent exercise baseline, exercise tolerance at baseline. But he's short of breath after walking half a block. He can barely walk. And he's normotensive. His heart rate's 133, and he's saturating 93% on room air. His troponin was a little bit elevated. His BNP was elevated. He had the S1 Q3 T3. And this was his CAT scan. This is the right main PA. You can see a clot here. You can see some clot in the left here. He had signs of RV dilation on the CAT scan, and on the bedside echo that we did, he had significant RV dilation. So he was admitted to the MICU. He underwent catheter-directed thrombolysis. So we did the 0.75 milligrams per hour of the catheter for 16 hours. And notably, when you put these catheters in, you can measure the pressures beforehand. And interestingly, his mean PA pressure was 40. And remember that you cannot achieve a mean PA pressure greater than 40. So he really is at the cusp of hemodynamic decompensation. And so the beauty of this is after 16 hours, you can remeasure the pressures. And the next morning, his mean PA pressure is 25. He was much less dyspneic and looked great. He was transferred to the floor and ultimately discharged home on rivaroxaban. The next case was a 60-year-old woman, history of morbid obesity, hypertension, diabetes, TIA. She was found unresponsive at home, brought to the hospital and intubated. This is what she had on CAT scan. If I can see it, it means it's pretty significant. So she had this hemorrhage in the frontal lobe. She ultimately did much better. She underwent a tracheotomy. She was weaned to trach collar. And she actually was transferred to acute rehab with plans of removing her trach. And she was there for 2 weeks. And then she started to have this persistent tachycardia. So her blood pressure was fine, but she was tachycardic to 118. And her O2 sat was 95% on Roumère. Chest CTA was performed, and you can see she had a large clot. You can also see she had RV strain, at least on her CT. So with neurology, we decided the PE team was called for this. The heparin drip was initiated, and she was obviously too high risk for any kind of thrombolytic therapy. Her echo did show moderate to severe RV dilatation and dysfunction. And so an IVC filter was placed. And she was kind of teetering. She was doing okay. But then 2 days later, while at line service, her systolic blood pressure dropped to 60s. Her heart rate was in the 130s. And I was called, and bedside echo was severe RV dilatation. And so the entire team already knew about this patient, and we very quickly decided to take her to the OR. I barely pressed send, and Ram Reddy was at the bedside wheeling her to the OR. So she goes to the OR. This is her TEE, her intra-op TE. This is the right ventricle. That's abnormal. That's clot bubbling in the right ventricle. This is what was removed. This is the right PA and the left PA. So wow, it looks like a lot of clot until you then look at the main PA, and you're like, that's an absurd amount of clot. Until you look at the right atrium, and you're like, what is going on? So she actually got extubated 2 days later, and she's doing well. So she's fine. And Ram actually saw her a few months ago, and she doesn't even have a trach even after the extubation, which is crazy to me. Third case, 73-year-old woman, obesity, hypertension, severe with residual left-sided hemiparesis, had a recent admission for a GI bleed, presented with presyncope. Initially, her vital signs were unremarkable. She had an elevated troponin, except overnight her blood pressure dropped. It was 60 over 43, and her heart rate was 96, but her saturation was 96% on Roumère. She got a little bit of fluid, and her blood pressure got a little bit better, and a CTA was performed. That's not subtle. So her left PA is completely occluded. This is a saddle PE. And she did have signs of RV strain on her CAT scan as well. Her echo showed severe RV dilatation and dysfunction. And later that afternoon, she had worsening dyspnea at rest. And her blood pressure was dropping. And when I saw her, she was incredibly dyspneic. And her blood pressure actually dropped below a systolic of 90. And immediately, by the time I pressed the button, Ram Reddy shows up and takes her to the OR. And this is what was removed. And she was extubated 2 days later and was doing great. This happened on a Tuesday. That following Friday, case number 4, 34-year-old man, history of obesity and diabetes. He was admitted for scrotal swelling and fevers, and essentially was receiving IV antibiotics for cellulitis. Was just hanging out receiving antibiotics. 10 days into his hospitalization, he had this episode of witness syncope while brushing his teeth. When the team arrived, he was diaphoretic and tachypnic, but was essentially following commands. His EKG showed sinus tachycardia, a new incomplete right bundle. His systolic blood pressure was about 80, and fluids were started. He was hypoxemic, placed on a non-rebreather. And so Mars was called, and Nan Lee shows up. She gets very embarrassed because I've told this story a lot. She's like, Hooman, why do you keep telling everybody this story? So I've decided to put her picture in front of the entire Department of Medicine. But ultimately, she is the major reason why the outcome of this case is what it is. She shows up with her ultrasound, and she notes that the patient was following commands but is hypotensive with very cold extremities. She does an echo, and this is what she sees. This isn't actually what she sees. This is a demonstration of what she sees, but she sees that the RV is severely dilated and impinging on the LV. And again, RV, this is a 4-chamber view, RV severely dilated, impinging on the LV. So she suspects that this is an acute PE. Heparin is started. She stops fluids and calls me and tells me that the plan is for CTA and transfer to the MICU, which was very reasonable. The only problem is the patient arrests 2 minutes later. He has a cardiac arrest, 4 minutes of CPR, 2 rounds of epi, and finally return of spontaneous circulation is achieved. So at this point, this is a massive PE. 10 milligrams of TPA bolus is given with plans to give an additional drip. He is intubated for hypoxemia and is doing relatively okay, except he arrests again. 4 more minutes of CPR, 2 rounds of epi, and at this time, we're just pushing more and more TPA. Because of that echocardiogram showing RV dilatation, the risk of PE was really high. We're just pushing more TPA. 40 milligrams administered, spontaneous circulation achieved, and started on Levophed. And again, pseudo-stable again, now ready to move, except he arrests again. So 40 minutes of CPR again, 2 more rounds of epi, and now another 50 milligrams of TPA. We're just dumping more and more TPA into this patient. So he's finally pseudo-stable on high doses of pressors, and is ultimately transferred to the ICU. And we get a CAT scan just to confirm this, and he still has clot. As you can see, this is the right main PA and left. And with the PE team, we decide that he go to the OR. He goes to the OR, and this is removed. So this is 2 days later, he is extubated. So in summary, hemodynamic perturbations in PE occur because of mechanical obstruction as well as pulmonary vasoconstriction. Risk stratification is crucial to determine the necessity of advanced therapies. So again, remember, a massive PE is defined by a low systolic blood pressure or cardiac arrest. A submassive PE is defined by RV dysfunction or myocardial necrosis, not by the amount of clot. With catheter-directed thrombolysis, we can give very, very low doses of TPA directed at the pulmonary vasculature. And the PE team is a resource for timely deliberation of high-risk patients for possible advanced PE therapies and rapid mobilization of resources. So thank you very much.
Questions?
After thrombolysis, reocclusion is usually with those bad platelets again. I'm surprised that there hasn't been more attempt to combine antiplatelet therapy with thrombolytic therapy, especially in a bailout situation at a minimum. Are there any trials planned or ongoing in that regard?
No, it's interesting because that's a great point. Part of the activated platelets result in this vasoconstriction, and that we have medications to reduce that. And there have been no human studies to look at that. But if you look at animals, if you pre-treat animals with COX inhibitors, which will then result in decreased thromboxane, and you give them PEs, they actually get less increases in their pulmonary vascular resistance and their PEs. So if you happen to get a PE, you should ideally have been on aspirin or some kind of COX inhibitor. Additionally, serotonin inhibitors have shown the same thing in patients, in animal models as well. But there haven't been anything done in humans. However, pulmonary vasodilators, there are case reports of using inhaled nitric oxide in severe PE. It's really...
But separate from the vascular resistance and serotonin, is the issue of whether or not the thrombus itself reoccludes after fibrinolysis. And when that's been looked at, highly potent antiplatelet agents just prevent that from occurring.
Yeah.
So the mechanical aspect, separate from the humoral one, I think is worth testing.
No, I think that's a good point.
So, given that the benefits and risks are relatively balanced in submassive PE, what's the role of the patient in the decision-making process? Does your response team ever talk to the patient about the balance of risk, or you're sort of making the decision more independently?
No, we obviously include the patient, and this is part of the problem with these studies is that the inclusion criteria are so variable and the primary outcomes are so variable. So there's the MOPIT trial, which I'm not going to get into, but the outcome of that trial is looking at 2 years later and some RVSP on echo and thrombolysis in that setting. So it's our duty that when we speak with the patient to tell them this is the intervention and this is the primary outcome that we're looking for, and that there is a real risk of bleeding and that the risk is, and we try to quote what we quote. At times it's difficult to really quantify that risk, especially when we're advocating for this catheter-directed thrombolysis. We don't really know what the bleeding risk is. And ultimately, we try to find reasons not to do it. So anytime someone has syncope and we don't know whether they hit her head or not, whether even if their CAT scan is fine, we don't even bother. So we really try to look for reasons not to do it. And when we speak with the patient, ultimately we give them the risk benefit of all the modalities, and they ultimately make the decision. But they just need to know what the options are.
Just done there. Thank you very much.
Okay.
And thank you very much for